Good morning. I'm Dr. Stephen Sherry, Acting Director of the National Library of Medicine of the National Institutes of Health. I'm honored to welcome you to the 6th Annual Lindberg-King Lecture, co-sponsored by the NLM, the Friends of the National Library of Medicine, the FNLM, and the American Medical Informatics Association, or AMIA. This annual lecture was established in 2015 as a forum to bring together insights on the current state and the future of bioinformatics and pathobiology to a broad scientific and public audience. With this purpose, this lecture honors the legacy and contributions of the late and former NLM Director, Dr. Donald A. B. Lindberg, and former NLM Deputy Director for Research and Education, Dr. Donald West King. Before I introduce today's distinguished guest speaker, I would like to welcome representatives of the FNLM and AMIA to offer some remarks and thank them for their co-sponsorship and participation in this program. We'll hear first from Glenn P. Campbell, Chair of the FNLM, followed by Dr. Gretchen Purcell-Jackson, President and Chair of the Board of Directors for AMIA. Glenn Campbell, over to you.
Thank you, Dr. Sherry. On behalf of Dr. Barbara Redmond, Dr. Andrew Ballas, who are President and Vice President of the Friends of the National Library of Medicine, respectively, and everyone on the board and all friends of the National Library of Medicine, it is my privilege and an honor to welcome you as well to the 2023 Lindberg-King Lecture, Got Community, Reflections on the Relevance of Community Engagement in Equitable Health Informatics and Data Science Innovations. The Friends are pleased once again to co-sponsor the annual Lindberg-King Lecture with our friends and distinguished colleagues at the American Medical Informatics Association. Dr. Lindberg, as Steve noted, is a former director of the National Library of Medicine and an innovative groundbreaker in informatics. And Dr. King, a biopathologist and an expert in education. They established the Lindberg-King Lecture in 2015. They would be thrilled in 2023 to welcome and listen to Dr. Suzanne Bakken, whose knowledge of biomedical informatics is widely heralded and whose passion for education and mentorship are globally recognized. Among Dr. Bakken's many laurels and honors are the Friends of the National Library of Medicine's Nursing Informatics Award, which she received in 2016. Her research and clinical expertise are noted for their patient focus and community engagement. Dr. Bakken's compassionate nature and capacity for empathy inform her professional life and writings, and no doubt will inform her words today. We remain grateful to and appreciative of our colleagues at the National Library of Medicine, the NLM Media Operations, to Derek McLean, including Dr. Sherry, Diane Babsky, and especially Jeff Resnick for their efforts to ensure that today's lecture runs smoothly, is engaging, exciting, and rewarding. It is my pleasure now to turn next to our very distinguished colleague, Dr. Gretchen Purcell-Jackson, Vice President and Scientific Medical Officer at AMIA. Over to you.
Thank you, Dr. Campbell. I'm Gretchen Purcell-Jackson. I'm the chair of the board of directors of the American Medical Informatics Association, and I'm honored to have a few moments in this forum to make a few remarks on behalf of AMIA, the leading scientific health informatics professional organization in the United States, and I believe an important part of the legacy of the National Library of Medicine. AMIA represents over 5,400 biomedical and health informatics professionals who work across academics, industry, health systems, nonprofit, and government. AMIA, as we know it today, arose from a convergence of professional societies and conferences, and Dr. Lindberg, who is honored today, played a key role in each component. Dr. Lindberg himself presented at the first symposium on computer applications in medical care, or SCAMSI, which was a local meeting in the Washington, D.C. area where engineers, scientists, and clinicians met to discuss scientific and clinically significant papers at the intersection of computers and medicine. Now, this meeting grew rapidly and became the place to be to keep abreast of the emerging field of medical informatics. At the 1982 SCAMSI meeting, Dr. Morris Cullen proposed the creation of the American College of Medical Informatics, or ACMI. ACMI was formed and elected its first class of fellows in 1985, and ACMI remains one of the highest honors one can receive for substantive and sustained contributions to the field of informatics. In the early 1980s, the American Association for Medical Systems and Informatics, AMSI, emerged as the leading professional organization for computer systems in medicine. By the late 1980s, if you're not confused with acronyms already, the overlaps of interest of the leaderships across AMSI, SCAMSI, and ACMI was substantial. And their three boards mostly agreed that a merger to form a single organization would be in the best interest of all. Dr. Lindberg was selected as the founding president of the new organization, which is AMIA, which was legally incorporated in 1990. The annual meeting of AMIA was called SCAMSI for the first 5 years after the merger, and in 1997 became the AMIA Annual Symposium, which is our flagship informatics scientific meeting today. The field of biomedical informatics has grown rapidly over the past several decades, from its roots, which were focused in clinical and medical applications, to encompass bioinformatics, public health, and consumer health informatics. In 2002, Dr. Donald West King joined the National Library of Medicine after a distinguished career as a pathology department chair, a dean, and executive vice president at the University of Chicago Medical Center. Dr. King served as the Deputy Director for Research and Education for the National Library of Medicine until 2008. He was an ambassador to a diverse range of scientific, public health, and library science organizations supporting the evolution of the National Library of Medicine's programs to keep pace with the diversification of the field of informatics. Dr. King was equally known for his generosity, his charm, and his wise scientific advice. So this year, AMIA is absolutely delighted to recommend Dr. Sue Bakken to deliver the Lindberg-King Lecture, and I could not think of a more appropriate person to honor Dr. Lindberg's and Dr. King's legacies. Dr. Bakken is this year's recipient of the prestigious Morris Cullen Award for Excellence, the highest honor for thought leadership in the field of informatics. She has made broad and deep contributions to the field of informatics, including leveraging technologies to address and care for the most vulnerable populations, as well as addressing inequities in health and healthcare delivery long before it was cool to do so. Like Dr. Lindberg, she's been a leader in informatics research, education, and publication. And like Dr. King, she is warm and generous, and she builds relationships across professional organizations and, of course, is well known for her wise scientific counsel. As a grateful recipient myself of a National Library of Medicine pre-doctoral fellowship, which supported my biomedical informatics training and PhD research at Stanford, I am honored for this opportunity to offer remarks at this NLM event, and I will now turn the meeting back to NLM Acting Director, Dr. Steve Sherry.
Thank you, Mr. Campbell and Dr. Jackson both, and once more for your participation and for our partnership on this annual lecture. As we begin, you will see a live feedback button under the video stream. Please use this feature to send questions to our speaker for our Q&A following her lecture. This will be moderated by my NLM colleague, Dr. Jeff Resnick. It is now my privilege and pleasure to introduce our distinguished guest, Dr. Suzanne Bakken, the Alumni Professor of Nursing and Professor of Biomedical Informatics at Columbia University. Following doctoral study in nursing at the University of California, San Francisco, Dr. Bakken completed a National Library of Medicine postdoctoral fellowship in medical informatics at Stanford University. The goal of Dr. Bakken's program of research is to promote health and reduce health disparities in underserved populations through application of innovative informatics methods. A major focus of her current grant portfolio is visualization of healthcare data for community members, patients, clinicians, and community-based organizations, including the creation of a visualization toolbox to address COVID-19 testing and vaccine uptake. Dr. Bakken currently directs the Precision and Symptom Self-Management Center and the Reducing Health Disparities Through Informatics, or READY, predoctoral and postdoctoral training program, both funded by the National Institute of Nursing Research, or NINR. Dr. Bakken has also served as principal investigator of the AHRQ-funded Washington Heights Inwood Informatics Infrastructure for Comparative Effectiveness Research, WISER, and its follow-up study, WISER for You, which is focused on promoting the use of WISER infrastructure through stakeholder engagement. Dr. Bakken has also received funding from the National Cancer Institute, the National Library of Medicine, and the Health Resources and Services Administration. She has published more than 300 peer-reviewed papers. In 2010, she received the Pathfinder Award from the Friends of the National Institute of Nursing Research. In 2019, she received the FAAHSI Award from the International Medical Informatics Association. She is an elected fellow of the New York Academy of Medicine, the American Academy of Nursing, the American College of Medical Informatics, and she is a member of the Institute of Medicine, now the National Academy of Medicine. Dr. Bakken, welcome, and thank you for joining us today.
Thank you so much, Dr. Sherry, for that introduction, and to Mr. Campbell and Dr. Jackson for their opening remarks. It's always it's such a privilege and so humbling to be invited to give this lecture. And like most folks, I really want to start off with some personal remarks because I'd say the Donalds and their Marys and I all share Columbia in common. I didn't know that we would when I first met Don Lindberg in 1986 in a wonderful reception for MedInfo 86 at the National Air and Space Museum. And I was introduced to Don Lindberg by David Shires, who was then the MA president. And he said, Don, I want you to meet Sue. She's a nurse studying informatics. I think you should give her some money. And one day he did, indeed. And we didn't know then that it would be an NLM funded training spot, or eventually I would get some additional money. But I wanted to just say about the Columbia connection is both Don Lindberg and Donald West King were medical residents at Columbia that in the College of Physicians and Surgeons. Don Lindberg actually met his Mary when she was working as a nurse in the Vanderbilt Clinic at Columbia. And of course, Mary Elizabeth King was also a graduate of Physicians and Surgeons for her medical degree. In addition to the positions that Dr. Jackson mentioned for Dr. King, he was also the chair of pathology at Columbia, and currently there's an endowed chair named after Donald West King and Mary Elizabeth King currently in our Department of Pathology. I wanted to just share this last email I got from Don Lindberg, and Dr. Sherry mentioned that I received the Francois Grammy Award, and I received it in 2019. And this is the last email I got from Don, and you can see it was by the time I physically received the award, Don had died, and so this email is really precious. And it said, "Congratulations, Suzanne. I would give a lot to see you dancing with Francois Grammy." I never had an opportunity to meet him because when he was in the height of his career, I was still becoming a nurse. But maybe I have a dance in my future in another space. It was wonderful getting to know the Lindbergs, particularly through the Woods Health course, and anyone following up on some remarks that Dr. Jackson made about Donald West King. When there would be times on the site when I was on the board of scientific counselors for Lister Hill, and I would end up being able to sit next to Dr. King at dinner, it just always made you feel like you had won the lottery, because it would always be such an incredible conversations. So now moving on to my formal remarks, I want to start with just a few definitions first. And these definitions come from a report from the National Academies called Communities in Action, Pathways to Health Equity. And I was very privileged to be able to staff this particular report when I was in the Nurse Scholar in residence at the Institute of Medicine. I guess it was about a decade ago. But we can think about communities in a number of different ways. But thinking about it from the perspective of it being a social unit with commonalities such as place, norms, religion, values, customs, or identity, of course, but also thinking about the notion of neighborhoods. But communities can also be electronic, and we certainly think about that from the perspective of informatics and data science, when communities may share a sense of a place situated in a geographical area, or could be a virtual space that is technology facilitated. The thing that we know about community engagement, and the evidence as well synthesized in this report that you see in the screen, is community engagement is really essential to advance health equity. And also there is substantial evidence that failure to appropriately engage with community negatively influences the clinical research process and its outcomes. So we have much documentation about randomized controlled trials that did not hit their recruitment outcomes, interventions that were developed and weren't able to be implemented because they didn't take into account the context of the communities. In recent years, there's no doubt that the National Institutes of Health and other funding agencies have really initiated many activities designed to facilitate the engagement process. From a personal perspective at the moment, a recent NIH initiative relates to its novel and exceptional technologies and research advisory committee. It's called Next Track. It's a committee that I've been appointed to, and the interim director of NIH charged the Next Track group to start a working group that's called Engaged, and this is really focused on engaging the public as partners in clinical research. And I am the co-lead of the Engaged working group, and we are charged with developing a vision and framework for including public voices in the design and planning of NIH-funded research, and more broadly around the dissemination of those research findings. I've talked about community engagement in many venues and through many different lenses. What I really wanted to do today was really to reflect on the relevance of community engagement in health informatics and data science interventions through the lens of epistemic justice. And I first heard about epistemic justice through a student-led initiative within AMIA that was focused on justice informatics. And then secondly, I recently heard a very engaging talk on this topic at MedInfo in Australia, and it really made me want to look at a number of things I'm involved with through that particular lens. Before I get to epistemic injustice, which I will define, I also want to just talk about, I have health informatics and data science named in my talk. And so one of the things we see are many different versions of what's informatics, what's machine learning, what's artificial intelligence, what's informatics, et cetera. And so depending on the lens of the field you come from, you might do a very different diagram of how these different things end up relating to each other. But one of the things that I find most useful is simply thinking about whether one is focusing on numbers as data, text as data, images as data is one way of looking at it. For the last few years, often I would say one of the things that's different about informatics rather than artificial intelligence is that we spend a lot more time worrying about the human in the loop. But certainly in the last 2 years, we've heard a lot more about human-centered AI. So now moving on to what do I mean about epistemic injustice? Epistemic injustice comes from the feminist philosopher named Miranda Fricker, who wrote this book in the 70s. And epistemic injustice is defined as a wrong done to someone specifically in their capacity as a knower. And you can think about it from a couple of related sub-concepts of epistemic injustice. Testimonial injustice occurs when a prejudice causes a hearer to give a deflated sense of credibility to a speaker's word. This may be individual or it may be at the structural level. The other related concept is hermeneutical injustice, and this occurs when a gap in collective interpretive resources puts someone at an unfair disadvantage when it comes to making sense of their social experience. This may be due to lack of concepts to express one's experience or a misalignment between one's experience and socially accepted concepts. When thinking about hermeneutical injustice, I think about one of my former postdocs' work. My Chulor is currently funded by the National Institute of Nursing Research for her work on pain communication for the Hmong population. And many of the older Hmong in particular really have more oral rather than written communication. So they were having major issues related to communicating with clinicians and getting adequate pain management. And so, for example, one of the concepts that came very clear in the work that Dr. Lohr did were concepts that are unfamiliar to me with my cultural heritage, but the notion of pain feeling like a rooster pecking your skin. And so very much this is an instance of hermeneutical injustice can occur, and the clinician didn't necessarily have and the patients experiencing the pain didn't have the interpretive resources. So Dr. Lohr is really focused on creating those types of communication tools that can help with that. The notions of epistemic injustice came into the health literature a little bit later, kind of mid-80s, and it's been addressed in some different ways. One is just notions of just the people who are ill in general, also from the perspective of people with mental illness, people experiencing pain. And much of this has to do with having clinicians discredit their lived experience of being ill, experience a mental illness, or their pain experience. Also, this has come up more recently in a Lancet Global Health perspective, is really thinking about how we collaborate in research and the notions of local contextualized knowledge versus the dominant perspective on that may come from scientists who are particularly trained to focus on generalizable findings, and thinking about how that plays out and really generating knowledge, and also ties to concepts that have come up in the literature related to things such as colonialist approaches to science, etc. More recently, and the literature has increased even since I heard Brian Chapman talk about this summer in MedInfo. More literature has been generated thinking about the potential of health informatics and data science innovations and their potential to perpetuate epistemic injustice. And so thinking about things such as conversational AI and the fact that the patient may not be able to articulate something like a symptom in a way that's understood by the conversational AI, and then end up having an inappropriate exchange, and particularly that patient could end up feeling like their experience is not being understood. When we look at it from the perspective of generative AI, of course, generative AI depends very much on the data that the tools are trained on. And so the issue ends up being that there can be that existing data may be seriously biased due to a lack of gender, ethnic, racial, social, religious diversity, among others. And so this ends up being a matter of testimonial injustice. And we really can think about this as missing or silencing of some voices. And so when we think about it from the perspective of interpretive injustice, there is a Dutch researcher named Georgia Posey, who's been doing some very interesting writings in this area. And she gives some examples of the potential harm that can come from machine learning, and particular digital phenotyping. And she uses the example of automated prediction drug monitoring programs that predict patient risk of misusing opioids. So we can think about that from that particular perspective of really having some systems or a phenotype produce a risk that is seen more as the ground truth rather than really taking into account what the patient's experience of that might actually be. And so, although there hasn't been a lot of attention in the informatics and data science literature explicitly approaching these issues through the lens of epistemic injustice, we do have much literature that has the potential to contribute to it. We can think about our body of literature on human-centered design of innovations, thinking about citizen science approaches. We have worked within health informatics, certainly on integrating patient knowledge work into ways of knowing. And we have technologies that provide access to data sources. For example, open notes can be really looked at as a strategy for really making it possible to mitigate epistemic injustice by providing access and allowing the individual to apply their capacity as a knower. We also have different types of strategies that can be focused on increasing capacity for comprehension, analysis, and interpretation of data and information. I'm going to walk through some examples of my own work and just viewing it retrospectively through the lens of epistemic injustice. So I want to make sure that it's clear this is a retrospective view, that I wasn't thinking about it directly from this particular philosophical viewpoint at the time I was doing the research. So I want to just briefly illustrate this through a few different projects. And so in addition to the support for the training at Stanford, this was my first money I got from the National Library of Medicine. And so for many decades, the NLM has had an incredible HIV/AIDS outreach program. And at the time, I was at University of California, San Francisco, where I might anecdotally add, I hired Dr. Jackson in her first faculty position But I had the opportunity because our school was working with the Glide Methodist Church in the Tenderloin in San Francisco. We had a clinic there. I was focused on putting some informatics resources in the clinic, and it provided the perfect opportunity because this was a homeless clinic where, besides being homeless, many people were HIV positive and all had, issues, mental health issues, etc. But we received a small grant through the outreach program to implement a web-based information resource at the church and its clinic. So thinking about this in the past, what we're really trying to do in this particular project is really to address hermeneutical injustice in HIV/AIDS care and self-management. Because so much of the issue we were dealing with was that although we've provided tailored access to high-quality HIV/AIDS information sites, many of them really required high literacy levels beyond what the clinic clientele had. And so we really needed to augment what we were doing with technology, with human information navigators. And we did this through our nursing informatics students who worked with the clinic to get people up on board. And I can say it was incredibly successful. It was a relatively small amount of money, but some individuals with help from their human information navigators just got very enchanted with the power that the access to these resources were giving them. And a number of them sought future training in the field of computer technology. And so it actually ended up being life-changing, moving them from being homeless to being employed and housed and some of those kinds of things. And so this really, when I think about my work in the community, this is where I feel like the first start was with getting this funding, probably in about 1998 or so. When I think about it from the perspective of my time at Columbia, one of the first projects that I did working at Columbia University Medical Center, which is in the middle of Washington Heights, a very vibrant, primarily Latino immigrant community. We were funded in the first round of the Clinical and Translational Science Awards, and the first opportunity to get a supplement to that initial grant. And if you can remember, at that point in time, all CTSAs were required to have a community engagement course. So that was part of the beginning. But the first study that we did as part of our supplement was really to understand barriers, enablers, and incentives for research participation from the perspective of our ambulatory care research network. So in this particular study, we worked with people in the community, community members, clinicians in the community, met with policymakers in the community as well. And I really came away with some really important lessons that I've taken forward in my program of research. So that is thinking about any study that we do, that it really needs to have multiple messages. So in addition to your scientific publication, it's critically important that you have a message for the community from which the participants came. It's important that the clinicians in the community have information that they can use as well in their care provision, and also thinking about our local policymakers, because they want to do right by their constituents, and providing scientific data to them that they can use for their work is vital as well. And so I've kind of continued that those ideas moving forward in my research. Where I really had the opportunity to do it at scale is in the study that Dr. Sherry mentioned, which was several grants from ARC and a project that was called the Washington Heights Inwood Informatics Infrastructure for Comparative Effectiveness Research, or we call it WISER for short. But the basic idea of this project really was the brainchild of Adam Wilcox, now a professor at WashU in St. Louis, was to really think about if you did the Framingham study, but with informatics tools and in the community of Washington Heights instead of Framingham. And so the basic idea was thinking about it from the perspective of a patient. They have many different data sources, inpatient, outpatient, home care, maybe long-term care. They could be in a trial. There was survey data as well. And we were going to pull together these disparate information and data resources into a research data warehouse, create a tool, which was called Research Data Explorer, that the researchers could use to improve the health of the community. And where my contribution to the project really comes in is in this area over here, which is really thinking about making sure that we integrate the community. So this wasn't the original intent, was not necessarily to return data to the community, but I felt it was vitally important given what I had learned in our earlier ACN study and the fact that we had spent tremendous resources collecting data from almost 6,000 Latinos, primarily in Spanish, so people who have typically been not present in research studies, that I wanted to make sure that there was a way that the research participants, as well as the broader community and the policymakers in the community, could have access to that data to do the work that they needed to do. But I knew from the perspective of thinking about giving it back to the community, we had, as I mentioned, we had data on almost 6,000 people, and we knew that the majority of the people had limited health literacy. So we really had to think about what would be the appropriate strategy. And so it made sense from my perspective to really think about how would we approach this through visual communication. And by what I'm talking about here is the conveyance of ideas and information in forms that can be seen, comprehended, acted on for both self-management and communication with healthcare providers. It was important that it be understood by individuals with varying levels of health literacy. And we had to make sure that it would be comprehensible in both English and Spanish. So we undertook a human-centered participatory design of infographics as a strategy for incorporating community members' lived experience. And this would be an example of facilitating testimonial injustice. So we did about a dozen focus groups, participatory design sessions in the community, most of them in Spanish, to iterate the designs for what we would use to return that data to the community. And so from the perspective of hermeneutical injustice, we were trying to mitigate hermeneutical injustice through using the infographics and a tool to tailor them so that we could return individual results to community members. And this would augment what we did in terms of sharing aggregate results with policymakers in the community, with New York Presbyterian Hospital, so they could use it to inform their service delivery and those types of things, and also information that we would give to, which we could make available to community-based organizations for the work that they were doing. So I just want to give you some examples of some of the things that we developed. So once again, we really used the participatory design process to make sure that we had the input of the community members, and we're working on the co-design. And then the infographics can be thought of as part of a strategy to mitigate hermeneutical injustice by providing a common communication tool. So one of the things that we wanted to do is to be able to share some comparisons between individuals data and comparisons with other women, for example, in the age group, so that individuals can have an understanding against others in how they were doing. And this is an example of a psychometrically sound fatigue measure, but the concept that worked well with the community was the notion of feeling run down. We also tried to communicate overall health, and we did this through the use of icon arrays. And for most instances, the icon arrays did not work very well, but they certainly worked fine in using stars for overall health. So as you can imagine, people were quite accustomed to seeing stars for things such as restaurants and movies and some of those kinds of things. So once again, we were wanting to give people their individual data and let them know how it compared to other people of their gender and age. This was, we incorporated a number of the patient-reported outcomes measurement information system, the PROMIS measures, which are a very frequently used common data element for NIH studies. And in this, everything is meaned on having 50 as average. And the way the PROMIS measures work is if you have more of what's given of the particular thing that's being measured, it means you have more of that. So in this instance, we're using a number line. We're using green and red colors, green for better, red for worse, and also specifically pointing out where their symptom score is. It was pretty interesting in looking at the self-reported symptoms over time and against in terms of the PROMIS measures, is the only thing where as a whole, our sample ended up being worse was really in sleep disturbance. And so this study was over a decade ago, but we now, every day it seems like we know how important sleep disturbance is to so many things that are going on in people's health. In addition to wanting to use visual communication to let people know how they compare to other people of their age and gender, and for much of this, we were using our own data in the community. So in other instances, instead of doing that comparison, because maybe everyone in the community, it was true, low vegetable consumption, lower than average physical activity. So just knowing how you do against everyone else might not be helpful for all things. So we also wanted to communicate how people compare with a criterion. In this instance, we had measures of body mass index. So once again, you see the notion of a number line that has continued to be a good way to represent different types of data we found in our work through the years. But we not only have the number line, we have the words that define what those areas are. We also have the bodies, shapes to give an idea of what those numbers might mean. We highlight what the individual's weight or BMI is in several different ways. And then we also included a definition along with it as a way of communicating BMI. I also very much wanted to have a way to communicating different aspects of health in a common visual. And this is actually a pretty challenging at least a somewhat challenging problem, because in some instances, it's easy to compare things like that have a common denominator. So we used a lot of CDC 30-day measures. And so it was easy to show those together. But when we were talking about these types of things had a different denominator. And so in this instance, we wanted to show physical health, physical activity, overall health, mental health, fruit and vegetable consumption, and then wanted to compare with ideal. We went through many iterations of this, and this ended up being the final visualization we came up with. And it's one of the things that's very hard is people have a difficulty imagining a proportion. So you see that little fruit and vegetable consumption. It's hard for someone without having the dotted lines around it to get a good idea of how far away they are from the ideal. So we found in this instance, by adding the dotted lines and then adding the ideal, people would get a better sense of where they were. We also wanted to help in terms of not only returning the results, but once again, from the perspective of hermeneutical injustice, helping people to make sense of the results. And why does it matter if your blood pressure is high? And so you see we display a blood pressure, and we also include the risks of high blood pressure. And one of the things that's notable in this, we include both the more colloquial term as well as the professional term, because we find in many instances their clinicians may be using the professional term. And so when we did our participatory design, we did it in person in our, Columbia has a community storefront in the neighborhood. We did them we did the sessions there, and everyone got a nice stack of our designs, and they get a variety of designs for each thing we're trying to measure. And they could write on them, give it back to us, do whatever they want with them. And so I'd say this was the one that walked out of the room the most. One of the things we queried people about in the participatory design was if their blood pressure wasn't high, would they still want to know the risks of high blood pressure? And because hypertension was so common in our community, they just felt, well, they knew someone with high blood pressure. So I would say if I had to bet which of our infographics ended up under a magnet on refrigerators, it would be this one. And in fact, United Healthcare uses this in their consumer dictionary, and people have done some further studies with this. Of course, this is to be able to do this, you want to be able to do it at scale. And so to be able to tailor the infographics, we created a system that we called Entice 3 for short, but that stood for electronic tailored infographics for community engagement, education, and empowerment. So you see two different kind of versions of this, one more of a programmer version and another one maybe a more broadly understandable version. But the basic idea is what Entice did is it took data as input, in our instance, survey data, attached metadata to it, would process both population level data and individual data, and then match that against our graphical repository to come up with the individual result of it. So after we continued the work of Wiser into some additional areas, we've done a fair amount of work in Hispanic dementia caregiving, using some of the processes and that we learned through the Wiser project. And initially, when we started doing this, we really did it from, I'd say, very much coming as my perspective as a nurse. We wanted to do something. We got our hands dirty and we did things probably a little less efficiently than we can do them these days, but it was very important to get that back. And so we've learned a lot of methods about how to go about this, how to automate it, how to evaluate it through the years. And the point of that ends up being as we were doing this type of visualization work, dealing with a number of different priority problems in our clinic, we began thinking about the idea of creating a toolbox. Could we create a toolbox that other people could use rather than just doing these studies ourselves? And the opportunity to do that really came through the NIH's RADx UP initiative, the Rapid Acceleration of Diagnostics for Underserved Populations. And so through two RADx UP grant, we really had the opportunity to integrate epistemic and justice-informed approaches to address disparities in COVID-19 testing and vaccination uptake. And we called our project the ReadyViz Toolbox. So as we imagined it, we had learned a lot about visualizations in the previous decade. And the idea of a toolbox was that it would take as input the information needs of the community, its output, as with Wiser, would be tailored infographics. And it could happen at individual and batch output. It would have the tailoring capacity. We would have the documentation, including methodological guides, et cetera, really trying to get a lot of what we've learned into the toolbox. And as we wrote the grant, we really thought about it from the perspective of the users could be clinicians, they could be healthcare organizations, they could be community-based organizations, or they could be researchers. Because the nature of the COVID response in New York City was so community-based, we decided to actually focus our attention on the use case of community-based organizations and really thinking about developing a toolbox that we could get into the hands of the community health workers that were so important in getting our communities tested and vaccinated during the pandemic. The idea behind this particular project, we wanted to decrease the disparities using culturally congruent health literate infographics. And we were hoping that this would support comprehension, informed decision-making, and motivate appropriate behaviors. This was a very interdisciplinary and collaborative project. We had schools at Columbia involved. In addition, in our first RADx UP grant was focused in Harlem, and there we worked with the Association to Benefit Children. And that initial funding was really focused around, primarily focused on testing, but we had the opportunity to begin to address vaccination there as well. We had an additional opportunity to get some more funding, and we decided to, for the first time, to incorporate some other health disparate populations in New York City, and that was with both thinking about Bangladeshi immigrants and also Chinese immigrants. So we ended up working with New York University Population Health and Medicine, and specifically with Project New Yorker, which focuses on the Bangladeshi population and the Chinese American Planning Council in the work. And so in this, and I can say that RADx UP was very serious about community engagement. And so it's a great match for us because we're very serious about community engagement. And so our projects, as other RADx UP projects, really started out with really understanding community needs, and for us, then we moved through participatory design and then developing a toolbox. RADx UP had common data elements, and I show you what some of the common data elements were. In addition to the RADx Up common data elements, we collected subjective health literacy and numeracy. Those were specific to our project because we felt, particularly for what we were trying to do, these were very important variables for us. And then we had a subset of people from the survey that we did interviews and focus groups with. And these were really focused on really trying to get at community experiences and beliefs about COVID-19 testing and vaccine, and also thinking about trusted sources of information. So in our ReadyViz project, we had about 1,000 participants. We started in Washington Heights and Inwood. They participated in both. Those populations participated in both testing and vaccination initiatives. So they're predominant in our sample. 64% Latino, 25% Black, and then 7% Bangla and Chinese through our targeted outreach. The majority were women. We did have these projects occurred over about 3 years, and during that period of time, at least 80% received at least one vaccination. So our sample that was biased in that particular way. One of the things that was really notable was, although people's subjective health literacy would indicate that most people considered themselves to be health literate, 34% answered the numeracy question that you see on your screen incorrectly. Which of the numbers represents the biggest risk of a disease? So if you can imagine, this was really important to know, because when you think about all the numbers thrown around about COVID, so in terms of testing, thinking about accuracy of test, in terms of the vaccine, risks of getting a side effect from the vaccine versus risks of complications from COVID. So having a third of our sample. And when I was first sharing this data, we didn't yet have the Bangla and the Chinese information integrated, but the accuracy level is the same in those populations as well. When we looked at it from the perspective of motivators and hesitancy concerns, very much focused on the family. This was not different across the demographics of the populations. Also, community, keeping themselves safe, keeping the community safe. And so these were things like we could think of in terms of crafting messages. And then key hesitancy concerns, side effects, don't know how the vaccine works. And so I'm sure you've heard many of these same concerns. It was important, the qualitative work was particularly important when we think about having 16% who said it was something that was other, and I'll get into that in a moment. When we looked at trusted sources of information, the healthcare provider was the most trusted source. This was followed by friends and family, which was above government news, coronavirus task force, etc. I was happy to see that social media was last in this. As I mentioned, we learned a lot from those survey data from almost 1,000 people, but we also learned some really important things from our interviews with community members. And it actually was easier to recruit for focus groups and interviews than it was for the surveys. I think people felt so isolated. They just wanted to talk about this and what were their thoughts and what they were worried about. So it did show the misunderstanding about how the vaccine works, particularly the speed of development. Something that didn't come up in the survey that was in the other was certainly worry about long-term effects for self and offspring. So for example, like this was, while we expected that there might be different cultural concerns, in our study, age seemed to be the primary driver of this particular concern, with people who were much younger being more concerned about long-term effects. And certainly for people in the childbearing years, people who were pregnant, people who were breastfeeding. Among the Buddhists, there was some concern that the vaccine conflicted with the religious belief of only having healthy things in your body. And many people strongly felt there was SARS-CoV in the vaccination itself. There was also a couple of things that came out only in our Harlem community, and that was the notion of wait and see. We had all this data coming out, but it was on average, and people are kind of like, that's on average, but I want to see myself more in the data. I don't care that if on average the side effect is this, but what is this like for people who are more in my demographic? And the prioritization of communities of color in both testing and vaccination received fear of racist intentions. And this was a quote from one of the interviews. Are we the guinea pigs? White people usually get everything first. In the last couple of months, I've been returning this data in the Harlem community, and this really has been reinforced. And one of the reasons that I have learned more in returning this data is some individuals, particularly in public housing, felt like they had gotten limited resources for prevention. So then when the vaccine was broadly available, they just weren't so sure. And so the fears of Tuskegee and all of those kinds of things are still alive and well, and thinking about this from the perspective of our community. So what did we really learn about this that really informed the design of the infographics? That it was important that we needed to address different types of tests. There were some concerns around that, clearly understanding vaccine mechanisms and platforms, really have a way to address key hesitancy concerns of specific populations. For instance, someone of childbearing age had different concerns than someone who was older. And other things that would be very important to allow branding from a trusted source in the community. We wanted to support cultural congruence, and we really need to have some good options for communicating risk and proportions, because so many of the one-third of the people got that numeracy question wrong. So we went into our participatory design phase, and we usually do that in two phases. We do a broad survey, just testing out some infographic components, and we all can remember those deep pharyngeal swabs. Then also different types of icons that we might use for social distancing or talking about our particular test. And then we followed with the participatory design itself, and that is really pulling some of those different infographics, different icons and design ideas into a more coherent story. We workshopped two different approaches, going with a traditional text box approach or going with a personified approach. I was personally concerned that if we went with personified, that people might not take it seriously. But as we went through the workshopping, it was very clear that the personified approach was what people felt would get the attention of the community. And to be able to, elaboration likelihood theory says, the first thing you have to do is to get somebody's attention. They can't attend to it if they can't do any action, and if you can't get the attention first. And so we ended up going through the participatory design process with the various communities. And this is our COVID-19 vaccine infographic. And so it uses what conceptual metaphor theory teaches it is it's important to have a metaphor when you're doing communication. And so the metaphor for this was really war. And so you see that through some of the different characters. You see that there's the good guys have lightsabers to, the antibodies have lightsabers to help fight the virus and that kind of thing. And so this is the standard set of information, and this builds on the needs we saw from the community, lack of understanding about how the virus makes you sick and how the vaccine works. Then as far as the tailoring aspect, we took the things that we heard and turned them into different questions with different icons that go along with them. And so in addition to having the standard information, a community health worker can select the things that are most relevant to the person that they're working with, and to have that create an individual graphic for them. So where we are in this is then we needed to take everything that we learned and turn it into a toolbox that others could use. You'll notice a name change here. It turned out that there was some software already called ReadyViz, I think, Toolkit. So we changed our, and we didn't want to get into any issue over confusion or of copyright. So we changed our name to the TaylorViz Toolbox. And so the basic idea, this is web-based software. Individuals can sign in at the organizational level. They have a repository of infographics. There are different functions at the organization level versus individuals within the organization. So they can select a base infographic. They can brand it from their organization, because the community-based organizations are the ones that have worked hard to have the trust of the community. They can add their logo. They can edit text, and of course they can tailor it to the individual needs in the instance of the vaccination. And so we have the infographics available in 4 languages: English, Spanish, Bangla, and simplified Chinese. So the idea behind doing that, and in our creation of the toolbox, we wanted to make sure that we were doing things that it would be scalable, it would be extensible to other type of community needs. So we've been careful about that and thinking about how we developed the software. So we have the opportunity to expand TaylorViz through our work on Ignite. And Ignite is part of the All of Us initiative, and it stands for Interdisciplinary Guided Network for Investigative Translation and Equity. And when we one of the Ignite activities is to host different types of experience in which individuals can interact with the All of Us researcher workbench. And this activity is this grant. The contact PI is my colleague Elizabeth Cohn. But one of the things that happens in the data sandbox activity is people are trained in the public use level of the All of Us researcher workbench, and they do a number of different activities to gain familiarity with the data. And this is customized to the group that the sandbox is being held for. And so one example is that they can do a treasure hunt, and this way people can search for information that might be particularly useful to their particular community. So how we're working with the program is adding the TaylorViz toolbox to the data sandbox. So not only, say you come from a community-based organization that is serving serving the Latino population, you will learn things about your community and about the population through the discovery activity as part of the toolbox. But then we will have pre-built templates of infographics. And so that as an additional aspect of return of value to the community from the All of Us researcher workbench, they'll be able to create an infographic that they can take into their community from their community-based organization. So I think of this as another example of a strategy to mitigate hermeneutical injustice, because we really are creating tools and resources that can help people make more sense of the data, and also to make additional use of it in ways that are comprehensible and culturally congruent. So in concluding, it's been fun for me to share my reflections and how I've been thinking about this. And I'm one of those people that just loves a good framework and being able to really think about things through some different lenses. So really looking at the role of community engagement in health informatics and data science intervention. My perspective is that this really suggests a couple of needs. Is one, we really need to broaden the diversity of input inclusive of lived experience in the creation and implementation of data sets, algorithms, and health informatics interventions. We really need to think about whose voices are being silenced or are missing, which can make those, can add biases and also fail to really advance health equity. We also need to develop different types of strategies and tools that facilitate community determination and prioritization of health-related needs and the kinds of resources that are needed to meet those needs. We also need to think about strategies and tools that can increase community capacity for co-production, translation, and dissemination of information and knowledge. I spent the last 2 days at a National Academies workshop that was on community safety as a social determinant of health, and I was the annoying audience member that would ask almost the same question in every panel, which was, does the community have the data they need? What type of tools would they need to be able to engage more as we think about interventions to make the community more safe? And one of the other places I'm going in my own work with the toolbox is really in the area of prevention of firearm injury. So in addition to thinking about that diversity of input and having some new strategies and tools, it's critically important that we apply or we develop science policy frameworks that support epistemic justice. And from my perspective, I think I'm very excited about the work that the Engaged Working Group is doing from the Next Track Committee, and also tied to the Directors Advisory Committee, because of its potential to really advance a science policy framework that would support epistemic justice. And with that, just some acknowledgments, funding, the importance of the community partners, the experts, both in visualization and culture, that have been reflected in the work that I've shared today. And with that, I think we can go to Dr. Resnick, who's going to facilitate the discussion.
Thank you, Dr. Bakken, very much for that wonderful presentation. Very thought-provoking and very important. We have a couple of questions to begin this morning. The first one is, could you speak to how these ideas play out in terms of publishing, the publishing ecosystem? Thank you.
Thanks. I really appreciate the opportunity to say something about that. I am the editor-in-chief of the Journal of the American Medical Informatics Association. And I've recently had the opportunity to really think about this from the perspective of the journal. And we spent time thinking, we've done a lot of publication in our journal about health equity, but I have explicitly made it a new goal for the journal moving forward, and it will be in our January 1st editorial. We traced the previous editors-in-chief of JAMIA and I did a historical look and felt that our initial goals were good, but we needed an additional goal in moving forward. And how this might play out is really thinking about some of the concepts that came up in that Lancet Global Health publication, thinking about, and that came up, was a lot about north-south relationships and the importance of where you are in an author's list and always having kind of the north scientists maybe being dominant and maybe not recognizing the importance of contextual knowledge. Some of these ideas, the importance and the value of local knowledge, came up a lot the last couple of days in the community safety workshop I was up, because people are saying, yes, science moves through generalizable knowledge, but when we're implementing things in a community, we really have to pay attention to that local knowledge. And so in publication, thinking about how do we value that generalizable knowledge versus having input of the contextualized knowledge that's so important for the application of science and in practice. And what are the different ways of knowing, and how do they get integrated into a publication and acknowledged in authorship?
Thank you very much. A related question has come in. Could you speak also to how these ideas play out in terms of the professional training ecosystem?
Yeah, I think this is incredibly important, and I think these ideas are not broadly incorporated into training programs in health informatics, biomedical health informatics, and data science. I've really thought about it a lot in the classes that I teach at Columbia. So we do integrate these notions. And so training programs are clearly addressing things such as algorithmic fairness and bias. So I think there's no doubt that kind of thing is there. But I think more broadly, really think about that notion of who's missing, silencing the voices, and really thinking about it from a person's recognizing a person's capacity as a knower. So I think the ideas are not widely integrated at the moment, but I think it's an important lens that our field can apply to look at training as well.
Thank you, Dr. Bakken. Another question: in your community conversations about community concerns and pointing to social determinants of health, to what extent did local history and experience play a part in these conversations?
No, it definitely comes up. And one of the things that I was wondering if we would maybe hear a lot about kind of the academia versus the community perspective. We actually didn't hear. We actually didn't hear so much about, well, Columbia or New York Presbyterian did XYZ in the past, and we don't trust them. In fact, those institutions the people in our sample had a high trust of healthcare providers, including our local institutions. But definitely the kind of historic atrocities came up predominantly more in Harlem than in Washington Heights and with the Bangla and the Chinese populations.
Thank you. Another question: what are your thoughts about dissemination of infographics through NLM's Medline Plus and connecting to patient portals via Medline Plus Connect?
Okay, absolutely. And I've had the opportunity to serve on in addition to serving on the Lister Hill Board Scientific Counselors, I've also had the opportunity to be a member of the Board of Regents. And there's definitely been conversations that we've had, or maybe when I was on the NLM Strategic Planning Group. But my idea was that every paper should have an infographic that would be very accessible to people with differing levels of health literacy, and that would go into, and that would be attached in PubMed, because I think it is important. And many journal publishing has certainly moved to many journals requesting a type of infographic, either as a graphical abstract or as a central communication. Not all of them are necessarily focused with thinking about the public audience. But I think this is very consistent with NLM's mission. What I've learned through the strategic planning process, as well as other things, is NLM engenders a lot of broad trust because of the PubMed resource. So anything that we can do to combat misinformation, advance trust in science, to attaching things that are more broadly understood in as part of PubMed, I think is a good thing in continuing to promote that trust.
Thank you, and absolutely agree, of course. Another question we have, this individual writes, I'm intrigued by the successful infographic regarding high blood pressure. Could you say more about effectiveness or impact of this kind of outreach or returning individual results on improving health in the community? Are there specific metrics, et cetera, that you used or are thinking about using?
Yes, for many of the things, when I'm going to talk about like kind of where is the focus of our science and our innovation, and much of what we focus on is really around the development of the infographics, the development of the tools, and then we collaborate with other researchers who use our resources to do the studies. That would look at the effectiveness. And so I can talk about a couple in general. We have someone has used the blood pressure infographic has been used by a stroke neurologist at Columbia in a study, and she has shown a post-stroke, used it in post-stroke, and they have shown a drop in blood pressure. And so that's an example of the blood pressure. One of our postdocs has done, Samantha Stonebreaker, who's now an assistant professor at the University of Colorado, has been working for about a decade on doing infographics in HIV, designed specifically for patient provider communication, and she has evidence in her study that she was actually able to show a decrease in viral load as the result of the communication intervention that included the infographics. And so the answer is we don't know the effectiveness of each of these things, but we make our tools available to researchers who want to do those types of studies with them.
Thank you. Could you say more about the process of developing the infographics? How were the texts in them composed, and how were the illustrations conceived?
Yes, and so we've used different strategies through the years. I consider our approach to be a hybrid approach. We start with a design brief and what the purpose of the communication, and do an environmental scan, what's out there, about like the conceptual metaphor that might be appropriate. So we usually go to the community with at least some general ideas. In the early days, we used and then we co-produce. In the early days, in Wiser, we did in-house, doctoral students, postdocs, etc. The members of our team did all the infographics ourselves. And then afterwards, we had specifically an urban Latino graphic designer kind of work on the designs afterwards to make them more culturally appropriate. We had done, ours were in much less vibrant colors. And so we worked with the graphic designer afterwards. Since then, we consistently work with a graphic designer. In some instances, like Sam Stonebreaker's work, she's had the graphic designer as part of the information needs assessment as well. So the graphic designer can work on the fly and say, well, how about this? In other instances, the team, particularly Adriana Arcia, who's the creative person behind this, she works explicitly with, has worked long term with a different set of graphic designers who help the designs come to life from the basic ideas that we have about how to do it. So it's varied over time, but we always include a graphic designer.
Thank you. Someone writes in, Dr. Bakken's lecture reminds me of the book, Spirit Catches You and You Fall Down, a story of the Hmong community's experience with the healthcare system in Fresno, California. Dr. Bakken mentioned work with this community and can share examples. And this individual writes and thanks you very much for your lecture. Dr. Bakken, we have time for one more question, and that is, what advice would you have for other communities and other medical centers for replicating this great success in your community? What advice do you have? What guidance would you offer them?
I think, it's clear that institutions have to get ready to do this. The funding agencies are very focused and more increasingly focused on community engagement, and institutions need to have the resources to help researchers that do this. And one of the outputs of our Next Track Engaged working group is to really produce not only a framework, but hopefully a toolbox that will help institutions be able to do this better. And so not every researcher needs to know how to do this, but an institution must have researchers and the institutional resources that make it possible for all researchers to be able to meet this goal of mitigating epistemic injustice.
Thank you, Dr. Bakken, very much. I would like to take this opportunity to thank you again on behalf of the National Library of Medicine, and certainly in cooperation with NLM Acting Director Steve Sherry, Glenn Campbell from the Friends of the National Library of Medicine, and Gretchen Purcell-Jackson from AMIA for a fantastic lecture, a thought-provoking, important, And we're privileged to host you this morning, and also to say that your lecture will be available in the NIH Videocast archive in a few days, so that many, many more people can appreciate the work that you presented and this occasion, which has been a privilege. The annual Lindberg-King Lecture co-sponsored by the NLM, FNLM, and AMIA. So Dr. Bakken, thank you again very, very much. It's been a privilege and a pleasure. Have a good day. And to all of you who tuned in this morning to hear Dr. Bakken's fantastic lecture, bid you farewell and a wonderful day, a wonderful weekend, and certainly also a healthy and happy holiday season. Thank you. Bye-bye.
Thank you for having me.